Radiation Protection Lesson 9 covers beam restriction and filtration, the two most powerful technique tools for reducing patient dose and improving image contrast at the same time. We cover the purpose of beam restriction, how scatter and contrast respond to field size changes, all four types of beam restricting devices, light field accuracy testing, and beam filtration, inherent, added, and compensating. 10 minutes. These concepts appear throughout the safety category of the ARRT. Beam restriction limits the X-ray field to only the anatomy of clinical interest. It simultaneously achieves four things. It reduces patient dose. Smaller field equals less tissue. Irradiated equals lower total dose. Having the field area reduces dose approximately proportionally. Collimation is the single most effective technique variable for patient dose reduction. It improves image contrast. A smaller field produces less Compton scatter inside the patient. Less scatter reaching. The detector means less scatter fog, which means better contrast between tissues. Dose reduction and contrast. Improvement happen from the same action simultaneously. It satisfies a regulatory requirement. Positive beam limitation, PBL, has been required on all fixed radiographic equipment since 1974. PBL automatically restricts the field to the image receptor size. But PBL is the regulatory minimum, not the ALRA target. Radiographers are obligated to collimate smaller than PBL whenever the anatomy allows. Collimation borders must be visible on every standard image. And it reduces occupational scatter. Less patient field means less scatter exiting the patient toward the radiographer. Collimation is not just a patient protection tool, it's yours as well. These two line charts make the field size relationship visible. The left chart, scatter production versus field area. As field area increases from 25 to 400 square centimeters, scatter production rises steeply. Nearly proportionally. More tissue in the beam equals more Compton interactions. Equals more scatter photons heading toward the detector. And toward the radiographer. The right chart, subject contrast versus field size. As field size increases, contrast drops, steadily, significantly. Wider field means more scatter fog mixing with the primary beam signal, reducing the difference in density between different tissues, which is exactly what contrast measures. The takeaway from both charts is the same: collimate aggressively. Every centimeter of field reduction simultaneously reduces scatter production and improves subject contrast. There is no other single technique adjustment that does both. For devices restrict the X-ray beam, in order from simplest to most versatile. The aperture diaphragm is a flat lead plate with a fixed opening, rectangular or circular. Fixed field size. No adjustment possible. Used in cephalometric units and a handful of other fixed geometry applications. Least flexible. The cone and cylinder extend from the tube port, mechanically restricting how far the beam diverges. Cones are diverging. Cylinders have parallel walls and provide more precise restriction. Used in dental radiography and some fluoroscopy applications. Also fixed geometry. The variable aperture collimator is the standard on every modern radiographic unit. 2 pairs of adjustable lead shutters, 1 pair for each axis, allow any field size. From very small to the maximum at the given SID. A light beam inside the collimator shows the field outline before exposure. Critical point: the light field is produced by a bulb and mirror. It shows field boundaries, but it does not replicate beam energy or quality. It only shows where the beam will land. And positive beam limitation, PBL, is the automatic collimation system required since 1974. It links the collimator to the cassette or image receptor size and the SID, automatically restricting the field to the receptor. At minimum, manual override is allowed but must be clinically justified. Again, PBL is the floor, not the goal. The light field that projects from your collimator must match the actual X-ray field. If it doesn't, every centering decision you make based on the light is wrong. The accuracy requirement, the light field and X-ray field, must coincide within plus or minus 2% of the SID in each dimension. At a standard 40-inch, or 100 cm SID, 2% equals 0.8 inches, or 2 cm. Maximum discrepancy per edge. The test: place radiopaque markers, penny's work, at the corners of the light field. Expose the X-ray field. Boundaries should align with the marker positions. If there is a discrepancy, measure it and compare to the 2% of SID tolerance. Failure means the collimator must be serviced and recalibrated before the unit returns to clinical use. Do not continue using a collimator that fails this test. Every exam taken with a misaligned light field has been centering off the actual beam. Tested at equipment installation, annually, and after any collimator maintenance or repair. Look at the chart on this slide. It shows two things across the photon energy spectrum, skin dose contribution in red, and penetration to the detector in green. Low energy photons, 10 to 20 keV, contribute 85% of skin dose but reach the detector only 2% of the time. They are absorbed almost entirely in the patient's skin. They add dose without contributing to the image. Filtration exists specifically to remove these photons before they reach the patient. Inherent filtration is built into every tube and cannot be removed. Glass envelope, insulating oil, and port window together provide approximately 0.5 to 1.0 mm. Aluminum equivalent. Added filtration, aluminum sheets at the tube port, removes additional low-energy photons after they exit the tube insert. The NCRP requires that total filtration, inherent plus added, equal at least 2.5 mm. Aluminum equivalent for tubes operating above 70 kVp. Below 70 kVp, 1.5 mm minimum. For mammography. Below 50 kVp, 0.5 mm minimum. The HVL, half-value layer, measures the result of filtration as beam quality. HVL is the aluminum thickness that reduces beam intensity by 50%. Higher HVL means a harder, better filtered beam. This is measured during acceptance testing and annually. Compensating filters, wedge, trough, boomerang, equalize exposure across anatomy with non-uniform thickness. The thicker part of the filter goes over the thinner body part, absorbing excess beam where less penetration is needed. 3 beam restriction and filtration questions. The answer is B. The answer is C, 2.5 mm aluminum equivalent. The NCRP requires minimum total filtration of 2.5 mm. Aluminum equivalent for diagnostic X-ray tubes operating above 70 kVp. This total includes inherent filtration. From the tube itself, approximately 0.5 to 1.0 millimeters. Plus added filtration at the tube port. This requirement exists to remove low-energy photons that add only skin dose, without contributing to image formation. The answer is C. Remove the unit from service for collimator. Recalibration before further use. At 100 cm SID. The maximum allowable discrepancy is 2% of SID. 2 cm per edge. A 1.5 cm discrepancy on a single edge may approach or exceed tolerance depending on the total across both dimensions. If the tolerance is exceeded, the unit must be taken out of service for recalibration. Every exam taken with an inaccurate light field has been centering on the wrong location. You covered the 4 purposes of beam restriction, the dual scatter and contrast line charts, all 4 beam restricting device types, light field accuracy testing, the photon energy dose contribution chart, filtration types and the NCRP. Minimum requirements, HVL, and compensating filters. Collimate on every exam. Every centimeter counts.